So I'm going to go ahead and introduce our next speaker, Dr. Ellen McPhail. She comes to us from Mayo Clinic, Rochester, so it's a little bit colder from up there. And she studies diagnoses of amyloidosis and malignant lymphoma. There are numerous types of amyloid, as you are all aware, and treatment is very important and based off of what type of amyloid there is. So her research leverages laser microdissection followed by liquid chromatography with tandem mass spec. So she is the one that tells you what kind of amyloid you have.
Perfect. Thank you for that kind introduction, and thank you for, I'll need that, for inviting me to speak today. So I'm very happy to be here. So as Yasmin told you, I'm going to tell you a little bit about what we've learned from mass spec as far as amyloid diagnosis and typing. So I will try to keep this moving. Where's it going? Oh, I see. Gotcha. So no disclosures. So we know what amyloid is. It's a group of clinical syndromes characterized by extracellular deposition of misfolded proteins. This is actually kidney amyloid. So you can see the circles are glomeruli, but they have the very nice Congo red positivity that polarizes. So we know what this is. And we know that it can cause progressive organ damage and failure. Many organs can be involved. We see this in every organ you can imagine. This is a heart conference, so we will focus on the heart, where you see heart failure with preserved ejection fraction, but it can involve other organs as well. The typical diagnosis sequence for diagnosis: the disease is suspected. There is a biopsy of a clinically involved site. As you all know, this is not necessarily necessary in patients who do not have a monoclonal gammopathy and there's cardiac disease suspected. We can do a diagnosis with PYP scans and other radiologic studies, but since we're talking about tissue, we will focus on the ones where you do need a biopsy. There's Congo red positivity, and then the next step, okay, you know it's amyloid, is to determine the identity of the amyloid fibrinoprotein. So there are 42 different amyloid types that have been described so far. Heart is sort of fortunate in that although we have seen about 10 different amyloid types in the heart, about 98% of cases are either ATTR or AL. And we also know that, of course, cardiac involvement is the single most important prognostic marker for amyloidosis. So in some ways, this is easy because it's just down to 2. But even with just 2, again, as you have heard already today and already know, the treatments for TTR versus AL are radically different, and you really don't want to get the answer wrong, because to put patients already compromised on the wrong therapy would be a great disservice. So it's imperative to type the amyloid correctly. So what is the optimal method? There have been multiple antigen antibody-based methods that have historically been used, like immunohistochemistry, immunofluorescence, EM. All these have limitations, and the limitations are that, one, there's a bias towards known types. There are 42 different types, but the panels that we do by IHC usually just target the most common ones. So that's one problem. The more important problem for the heart is the chemistry is non-specific. So if you do immunohistochemistry, and sort of historically, and this hasn't changed over 20 years, that the inconclusive rate is very high. It's over 50%. This has a variety of reasons. So IHC is great for pathology for many purposes, but for amyloid typing, it doesn't work very well. So there's non-specific staining, there's cross-reactivity. And so this inconclusive rate can either just delay diagnosis, or even more ominously, you can actually think it's conclusive and it's not the type it actually is. So there are dangers to IHC. So we have felt that optimal patient care requires more accurate typing. So because of this specific problem, we developed and launched the world's first clinical test to type amyloid by mass spec-based shotgun proteomics. And this is now considered the gold standard and is performed by many labs worldwide. So just to show you this, so why is it so great? It directly analyzes the proteins of interest. It is unbiased, so it shows you all the proteins that are present. So it unambiguously identifies all amyloid types in a single assay, so it doesn't take much tissue, extremely high sensitivity and specificity. It uses paraffins. We just did a study on patients from the 1970s, worked fine. And it needs a very, very tiny amount of tissue. So a tiny heart biopsy, tiny kidney biopsy, we can make it work. So the reason it works so well is the sample is enriched for the amyloid using laser microdissection. So this is a kidney just to make it easy to show. Again, the pink circles are glomeruli that are involved by amyloid. And what we do is on the far right, you see the same Congo red, but under a fluorescent scope. So the amyloid looks bright red. A very fine purple line is the line of the laser. So what we do is we microdissect tissue that falls into a cap. And there it is. And then that's tissue that we actually analyze. So it's enriched and that enhances the analysis. This is the process. It's not too important to go through the details, but in the end, we end up with a scaffold. That's that green graph. We do every sample twice to make sure we are reproducible. The top 3 proteins that we see are universal amyloid proteins. So they're seen in amyloids of all types. So that helps confirm that we actually are analyzing amyloid. And then we see all the proteins that are potentially amyloidogenic. And the numbers are a measure, semi-quantitative measure of abundance. So in this case, we see that the most abundant protein is transthyretin. So we know this is TTR amyloid. And this is just to show you, this is a study we did of 18 different amyloid types. Each column is a different amyloid type, and all the proteins you see in the rows. The top 3 rows are the universal amyloid proteins. So you can see that all the cases had at least 2, if not 3 of them, but then each case just had a single type. So this is, for instance, the one I'm highlighting is an insulin case. That's the only type that had insulin. So it's an extremely good test. And the reason it works so well, mass spec is historically not so great because of QC issues. So we have extremely high and strict QC standards to make sure this test works properly over time. So we do a comprehensive analysis, looking at the tissue, the scaffold, the patient history before we establish a diagnosis. So this is now considered the gold standard per the CAP. This just came out. And this is also just quickly to show you that all those yellow boxes are different labs around the world doing mass spec. So it is actually done worldwide at this point. So here are the message I want to tell you. So mass spec is superior to IHC for amyloid typing. And I'll show you a case to illustrate this. This is a patient, 80-year-old lady, had a history of MS since 1999. She had a variety of complaints that could certainly be compatible with cardiac amyloidosis. At the same time, she actually had a GI issue, which led to a cholecystectomy, and amyloid was found incidentally in that gallbladder specimen. And so here it is, and you can see that those the Congo red highlights the blood vessels that are thickened and are Congo red positive. So we know it's amyloid, and the outside institution did immunohistochemistry for AA, I think because of the the multiple sclerosis history. I know you're not pathologists, but you can see that brown kind of staining in the vessels. This was interpreted as positive. So the patient came to our Mayo in Rochester, and the clinician said to me, this doesn't make sense clinically. Can you look at this? So we got the tissue, we did mass spec, and as you can see, it is in fact amyloid, but it was not AA, it was transthyretin. So, and this actually is not surprising. We know now, we just did a study on gallbladder amyloid. We know that over 50% of cases, when you find amyloid in the gallbladder, it's TTR type. And more importantly, all the patients who had clinical follow-up, they actually all had systemic cardiac disease. So this could be a potential clue of a more serious diagnosis. So I know along people have been saying that surrogate sites are not too useful. I would say that sometimes they have their uses. So in AL type, fat aspirates and bone marrow together, the sensitivity is about 85%. So it's not without use in AL. I think it can also be useful in TTR, and this is where you may have a patient in whom you suspect TTR. They have a monoclonal protein, so you can't base your diagnosis on a PYP scan. You could consider looking at another anatomic site that may have been biopsied or analyzed recently, like a GI tract or a prostate biopsy or possibly a gallbladder. Because what we have found, we've been studying these different anatomic sites, and we're finding consistently when we find TTR amyloid in these sites, they all have cardiac disease. So this is something that you think about using. Yeah, you might be a way to spare a patient a cardiac biopsy if you can go back to a recent specimen. And your pathologist, as good as we are, if you have a prostate biopsy, your pathologist is probably wondering about, is there cancer there or not? They may not be looking at the blood vessels and thinking, oh, maybe this is amyloid. So you need to ask your pathologist to go back to the specimen, do a Congo red, and think about it, because it's possible that those vessels were overlooked. So this is just another way to maybe spare a patient a heart biopsy. So then this leads to my next point, which is that surrogate sites can be useful, but they're not perfect. So if what you find on the surrogate site does not fit the clinical picture, then you have to think about biopsying the target organ. Here's another example. This is a patient, 73-year-old man, had longstanding diabetes. He had symptoms that certainly could be compatible with cardiac amyloid. He had elevated free light chains and an MGUS, and he had a positive fat aspirate, and he had a bone marrow that had 5% monoclonal kappa plasma cells. So the working diagnosis at this point was systemic AL kappa amyloidosis, quite reasonably. So here's the fat aspirate. You can see it's Congo red positive. We typed it, and it turns out this is not AL, and what it was insulin. So this is the site that was biopsy was actually where he had been injecting. So insulin amyloid is a thing. It's the fifth most common amyloid type that we see. In fat aspirates, it's probably about 10% of cases, so it's not that rare. In of itself, it doesn't mean much for the patient. It's kind of like a red herring, but it's something to keep in mind when you get a fat aspirate. So our clinicians rightly realized that this patient could have a systemic amyloid in addition to this localized insulin that was the red herring. This is a paper we just published about 111 patients who have dual amyloid. So patients can have two amyloid types, either in two different anatomic sites or in the same anatomic site. So it's possible for someone to have TTR and AL in the same heart biopsy. Just keep it in mind. We don't see it too often, but it can happen. Any case, so they realized, they went to the target organ, got a heart biopsy. He did have amyloid present. We did the mass spec, and it turns out the proteins were present, and it turns out that this was transthyretin. So this was not AL at all. This was TTR. So in the end, he had three diagnoses: systemic TTR wild type amyloidosis, and then an incidental insulin amyloid, as well as an incidental MGUS. I think this is a very instructive case, not because it's rare, but in fact, it's not rare at all. This is not a zebra. This is a horse. Because if you think about who gets TTR, okay, it's older patients, often gentlemen, which this patient was. Many, many patients are on insulin therapy. It's something we don't even think about too much. So insulin amyloid is probably grossly underdiagnosed. It doesn't really matter because it's not clinically important, but it might be important in this case. And you keep in mind also that TTR patients, about up to 40% of them can have an MGUS. So the MGUS with TTR is not a rare finding. It's common. A few more messages and then we're done. So mass spec, in addition to identifying the amyloid type, can actually identify the amino acid sequence variants in hereditary amyloidosis. So when we do the studies, we use the standard analysis is using a SwissProt database. Based on that analysis, we come up with the amyloid type. So this is an example of TTR. We can then run the same data through a different database. This is an amyloid mutation database, and that can demonstrate a specific mutation. So this is kind of very useful. This sensitivity is over 90% for this. It's actually kind of interesting because if you think of a patient with variant hereditary TTR, they will have that gene abnormality from birth, but of course they don't have disease from birth. Whereas when we see it in actual amyloid tissue. So we know not only do they have the mutation, but they have the disease. So, and then the mass spec, because we see all proteins that are present, this has helped us to identify new amyloid types over the years. These are about 6 we've identified in the last few years. And as time goes on, we keep identifying more and more amyloid types. So this is useful for future identification of patient types. So in conclusion, tandem mass spec is now the gold standard methodology for amyloid typing. It unambiguously identifies all amyloid types in a single assay with very, very high sensitivity and specificity. I think surrogate sites do have a purpose, either going after a surrogate site for the amyloid question or going back to a pre-existing specimen, as it may be a way to spare the patient a heart biopsy. However, surrogate sites are not perfect. So if what you observe on the surrogate site doesn't fit clinically, then you have to go to the target organ. We can identify hereditary types. And basically, I would say that the success of our program is really due to a strong QC program, at the amazing lab that we have, and the fact that we do the analysis by a small expert group. So there is a small group that the expertise is helpful for all of our analyses. So with that, I just want to thank our lab and our proteomics physicians, and I guess we'll do questions later. So thank you.